Welcome to our sonography lecture on renal pathology, part 4 of 14, malignant renal neoplasms for the sonographer. This lecture is going to cover renal cell carcinoma, transitional cell carcinoma, squamous cell carcinoma, metastases, lymphoma, and staging of renal cancer. Let's go ahead and start then with renal cell carcinoma, also known as RCC. Now, this is a primary cancer of the kidney which arises from the tubules of the nephron. Renal cell carcinomas are also known as renal adenocarcinomas, hypernephromas, or Grawitz tumors. Renal cell carcinoma is the most common renal malignancy. It's more likely to be in men at a 2-to-1 ratio, and it typically develops in men between 60 and 70 years old. Clinically, these patients are first going to present with hematuria, or blood in their urine. They may also present with some flank pain, a palpable mass, and they might start to present with classic cancer symptoms such as fatigue, weight loss, loss of appetite. On ultrasound, renal cell carcinoma is going to appear iso to hypoechoic to the renal cortex. It's important to note, though, that very small renal cell carcinomas can actually be hyperechoic. There's also going to be a hypoechoic pseudorim around the lesion, which actually is a vascular rim. There will be calcifications within. The mass itself can actually be very heterogeneous, especially the larger it gets. As it gets larger, it's more likely to start to necrose in the center or have hemorrhage or cystic spaces within. And when we put color on renal cell carcinoma, we expect to see internal flow with a low resistive indice. Here's our first example of renal cell carcinoma. We can see that it is on the hypoechoic side, rather large, irregular borders, and a solid structure within the kidney. Another example of renal cell carcinoma, this one is on the smaller side, so we can see that it is a little bit more hyperechoic compared to the cortex. Again, solid structure within the kidney. Here's another rather large example of renal cell carcinoma. We can see the kidney kind of off to the side here, but then we have the carcinoma hanging off the end here. It's rather large. We can see that kind of pseudo rim. The walls are irregular. We have a heterogeneous center. Here's an example with color turned on. We have that vascular rim around the outside of the renal cell carcinoma. And then we also have internal vascularity. Our next carcinoma of the kidney urinary tract system is transitional cell carcinoma. Transitional cell carcinoma is the primary cancer of the collecting system. So that does include the collecting system in the kidney, bladder, and the ureters. And this is going to arise from the epithelial lining of the collecting system. It also comes in 2 growth patterns. We see transitional carcinoma as flat growth, so it is barely raised above the epithelial lining. Those actually make them really hard to see, and they tend to be more aggressive cancers. The type that we can usually see by ultrasound then is the papillary version, and the papillary version extends out from the wall and thankfully is sometimes benign or a very slow, low-grade cancer. Transitional cell carcinoma is the most common collecting system cancer, but only accounts for 10% of renal cancers. So walking that back a little bit, renal cell carcinoma is the most common malignancy of the cancer, accounting for most of the cancers of the kidney. Transitional cell is the most common of the collecting system, so the renal, pelvis, bladder, and ureters, but we don't often see transitional carcinoma in the kidney at the pelvis. Just like renal cell carcinoma, transitional cell carcinoma is 2 times more likely in men and also typically develops later in life around 70 years old. Clinical signs and symptoms are very similar as well to renal cell carcinoma. The first one usually being hematuria, again blood in the urine, flank pain, or classic cancer symptoms. Now in ultrasound, we are going to see a hypoechoic mass within the collecting system. And because of where that mass is growing in the collecting system, it can actually cause obstruction. So we might see a mass surrounded by fluid or urine in the pelvis of the kidney. Transitional cell carcinoma typically doesn't exhibit much for blood flow. There usually are not any calcifications. We do know that transitional cell carcinoma can invade into the renal parenchyma, but it usually doesn't invade into the kidney and then start to distort the contour. It'll just kind of extend into the renal medulla or cortex. So comparing renal cell carcinoma to transitional cell carcinoma, renal cell carcinoma, most common kidney cancer, transitional cell carcinoma, most common collecting system cancer. Renal carcinoma is going to be found more in the cortex of the kidney, where transitional cell carcinoma is going to appear more in the pelvis. Renal cell typically has calcifications, heterogeneous, lots of blood flow. Transitional carcinoma has little color flow, usually no calcifications, and typically kind of stays within the pelvis of the kidney. So here are some examples of transitional cell carcinoma. We have the kidney here, so we have the cortex out here, and what we can see in the center is a hypoechoic structure in the pelvis of the kidney. So remember, renal cell usually comes from the cortex. Transitional cell is going to be found in the pelvis. Here is another example of transitional cell carcinoma. Again, we have the kidney cortex is all the way out here. We're really focusing just on that echogenic sinus here, where we can see kind of this irregular structure within. And we can actually see a little bit of fluid here and here, which represents the obstruction that this transitional cell carcinoma is causing. And another example of transitional cell carcinoma, again, renal cortex along the outside. We have the renal sinus, this echogenic part, and then we have this hypoechoic part extending through the pelvis, causing obstruction where we can see fluid on either side of it. And another example, this is that papillary form that we were talking about. We can see it extending away from the wall, irregular borders within the collecting system, again causing obstruction. So this one is surrounded by fluid. Our third cancer of the kidney is squamous cell carcinoma. Now, squamous cell carcinoma is actually pretty rare, but it is also a very aggressive cancer too. So it's rare, but has a really high mortality rate. This is also a primary cancer of the kidney, and this one occurs because of recurrent irritation, inflammation, or infection to the renal parenchyma. So what we usually see that coinciding with is the presence of stones, or especially staghorn calculi. So kidney stones, as they are moving through the collecting system, they scratch and irritate that lining, and that lining tries to heal itself, but it becomes irritated, it becomes inflamed, it becomes infected during that process, and then it kind of heals itself. And so that process just kind of happening over and over and over again does eventually damage the lining of the collecting system, which once cells are damaged and kind of try to reproduce a lot, they have a potential to not reproduce the same way and turn into a cancer. And so that's why we see the squamous cell carcinoma with people that commonly have recurrent stones. We'll learn later in this lecture series about staghorn calculi, but just as a preview, staghorn calculi are giant stones that fill the entire renal pelvis. And so these stones are very irritating to the kidney and cause blockages and lots of issues for the patient. So squamous cell carcinoma is associated with stones. What we will typically see then on ultrasound is a large mass within the pelvis. We might see those stones, and if there's obstruction, we'll see fluid or hydronephrosis within the pelvis. So here's an example of squamous cell carcinoma, renal cortex all the way around. A little bit of the sinus can be seen here. We have this large hypoechoic mass within the pelvis of the kidney. Here's another example of squamous cell carcinoma. Again, we have the renal cortex along the outside here. The arrows are pointing at parts, stones within the kidney. So those are the bright echogenic areas. And then the star here is on the squamous cell tumor. Metastases then. Metastases to the cancer are a cancer that is found from a separate primary source that eventually travels and causes tumors within the kidney. Metastases to the kidney is relatively common. They're more likely to come from lung cancer, breast cancer, or renal carcinoma of the contralateral kidney. So right kidney has RCC, not uncommon for it to metastasize as RCC to the left kidney. On ultrasound then, we're going to see multiple masses exhibiting pore borders. We might start to see some invasion of the mass into surrounding tissue or into blood vessels in the area. So in this image here, we can see again the renal cortex. We have liver up here, and then we have a renal mass extending through. Now, this one is a little bit trickier to tell. It's kind of hypoechoic. It's kind of spreading into the cortex and the sinus. So this is more likely a metastases, kind of presenting in an irregular way. Our last cancer of the renal system then is lymphoma. We know that lymphoma is a primary cancer of lymph nodes that can affect multiple organs in the body, and this does include the kidneys. There are two different ways that lymphoma can spread into the kidneys, or really into any organ in the body, and one of them is through hematogenous spread, so that means that it spreads through the blood, or it can spread directly from a lymph node nearby to the kidney and extend into the kidney itself. There are two variations of lymphoma, non-Hodgkin's lymphoma and Hodgkin's lymphoma. Non-Hodgkin's lymphoma is more common to extend into the kidney than Hodgkin's. On ultrasound then, the kidneys are going to appear very large with lymphoma extension, and we might start to see some hypoechoic masses within that almost look like they're cystic. The only thing is that they do not have that through transmission. So if you remember back to our Bosniak scale, looking for that through transmission is an important piece of it to rule out any cystic type cancers. So here's an example of lymphoma within the kidney. This is a transverse image. We have the renal cortex, sinus, hilum here. We do have a lymphoma that is extended into the kidney here. It is very hypoechoic, maybe a few low-level echoes within there, but the big part is there no through transmission behind it. So this is a lymphoma within the kidney. The last thing that I want to discuss then is staging of renal cancer. Staging of renal cancer is actually preferred to be done through MRI or CT. Really, they can just see lymph node involvement, they can see vascular involvement, they can see how the tumors have expanded within the kidney or beyond the renal parenchyma. So it's just more of a global view than what ultrasound can do. Ultrasound is a great tool for identifying abnormal structures in the renal area, but MRI and CT are going to be much more useful for staging and doing that kind of final diagnosis. It is always important then to know your cancer symptoms. The classic cancer symptoms do include weight loss, leg edema for renal cancer, nausea and vomiting, fevers that don't go away, and extreme tiredness. This diagram then shows us nicely how we stage renal cancer. Stage 1 is a tumor that is less than 7 centimeters and resides still within the kidney. These actually tend to have very good survival rates, as they can just go in and remove the kidney or remove the cancer, remove part of the kidney, do a partial nephrectomy. And so these are typically very easy to cure. It's this purple one here. Stage 2 then is when we get to a larger than 7 centimeter mass, but it still remains within the kidney. And again, those are actually pretty good survival rates as well, because it's easy to remove the kidney and be done with it. We see the survival rate starting to go down with stage 3 and stage 4, as stage 3 starts to see expansion of the tumor outside of the kidney, but still within Gerota's fascia. Remember, Gerota's fascia kind of covers the whole perirenal space. And so we can see that here in the yellow, expanding beyond the renal border, but still within Gerota's fascia. The other thing that we see with stage 3 is that we might see some extension into the renal vein and possibly into the inferior cava. So this is a really big reason why we look at the IVC, seeing if there's any tumors that are extending into it from surrounding organs. We might also see some involvement of lymph nodes with stage 3 as well. Stage 4 then is when we start to see the tumor extend beyond Gerota's fascia. We definitely have it in lymph nodes, and it's more likely to metastasize at this point as well. Much harder to remove all the items that are affected by the renal cancer at that point. And that brings us to the end of malignant renal neoplasms. We're going to pick up next on benign renal tumors.